Hey everyone, Robert Rayleigh here to discuss how calcium morphology affects sort of calcium treatment and patient outcomes. So as we've learned more about calcified coronary lesions, as we've got more technologies to treat it, more imaging data to show what a spectrum these lesions really go through, we've realized that there are distinct entities of calcified lesions and that technologies may work differently in those different buckets of lesions. On the one end, we have calcified nodules, and under that we have both the eruptive and the non-eruptive type. The eruptive meaning that thin fibrous cap has been disrupted, and there's usually some thrombus associated with that. Those lesions tend to recur and can be very, very tough to treat, both in the short and long term. Then there is the non-eruptive nodules where that cap is still intact. And then on the other side, we have your eccentric versus concentric calcified lesions. Concentric meaning your calcium's 360 degrees versus your eccentric being anything less than that. We know that, for example, with nodules, atherectomy doesn't really change outcomes. We know that IVL looks like it may. There's a really nice small study published out of the Disrupt CAD3 showing really good results there. Again, truth is still out there, still searching for that. Maybe an atherectomy first to shave the top off the mountain with an IVL to really get at the base. Again, we're still evaluating that, but it's important to know if you have a nodule because they can be very difficult to treat. And if you're going to treat with IVL, you need to lay a lot of pulses on there in order to finally get some deformation and typically use an NC balloon afterwards. Typically, we often recommend using NC after IVL. Not everyone does, but I think with nodules, it's really important as well. And again, putting a lot of pulses on that. Then on the other end, we have our concentric versus eccentric. Well, we know concentric really responds very well to IVL, and it makes sense, right? The balloon is putting out those treatment ultrasound all over in that 360 degree, and we're able to really get those lesions done well. Now, does IVL work in eccentric as well? It does. We've seen that in some studies. Many question, do you need anything at all when you're eccentric? Because you're essentially everything you use is going to push away from that eccentric calcium there. Again, I still think that we are looking for that. I think it's important when you have long lesions to determine areas where there's concentric versus eccentric. With our C2+, it's nice because we're able to deliver a lot of therapy in all the segments, but I think you want to key in on those concentric areas where you know it's going to work well and is really needed. And then with the pulses that you have left over, really focus on those eccentric areas as well. So again, I think it's key to identify the types of calcium that you have, because I do think it affects what type of calcium modification device you're going to use, and I think that will help your patients both in treating them on the table and then in their short and long-term outcomes in terms of state and vessel pendency.